waiting for others to join.
Check 1, 2, check. Yeah, so that's good. So I can hear myself. So notice the camera trigger us because we spoke last. So we mute ourselves. Check 1, 2, check 1. That's all you do.
Okay.
And you want off, press on hold.
Hi, it's Terry at St. Paul's, just making sure you can hear us.
Hey, Terry, it's Wei at the DXCC. We can hear you, but we cannot see you because you got a black, no camera.
Oh, okay. Let me just have a look at that.
Yeah. So I'll wait for you.
Can you hear me, Wei? I'm on top here.
Yeah, you stole obviously you used the dual to demonstrate your camera view, so I see that camera, that left turn, the very far left turn camera, it's working. But I'm not sure you're using for the other camera, how many cameras you have in that room.
Well, we've got an audience camera up front, I guess, basically, and then we've got one for the back of the room for the podium. So there should be a wide shot right now of that.
Sorry, I cannot understood a word you said.
Sorry, I was at the back of the room. So we've got a camera that shoots the podium from the back of the room, and then we've also got a camera that shoots the audience from the front.
Right.
And are you seeing?
I am seeing a far end shot of you.
Yeah.
So, but it's in our main. You stole the. I'm sorry. You stole the dual. So you actually forced the camera down the dual.
Yeah. Sorry about
That's
that.
okay.
I'm just trying to see what's going on here in this room. So main camera. If I choose.
Okay, there you go. I got the main, your camera down the main now. It's perfect.
Yeah. Okay.
Is there another camera to the audience or?
Well, let me just try this. I'm not sure. There we go.
Oh, there you go. We got the audience. Awesome. So we'll leave it at that, and I'm going to take the dual back. So you're going to see the slide, expensive drugs for rare diseases.
Yeah.
And just give me a confirmation that you see the slide.
Got it.
Perfect. Okay, thank you very much, Terry. Mute your mic, and then we consider this as a flash.
Thanks, Wei. Actually, we can't mute the mic in this room. It's not built that way.
Oh, okay. Well, then I'm going to let the client know here that we'll hear some noise from St. Paul then.
Yes, they will. We're actually looking at maybe getting an upgrade for this room if somebody springs some cash on us. So we'll cross our fingers on that.
Well, okay. We can always hope for that.
Yeah.
Okay, I'll let the client know. Thank you.
Thanks, Mike.
Joviality for 726.
So my hands, you can imagine.
Oh my God.
How is he doing? He said home he got stroke to me.
I went to the Mama year yesterday as dessert. We weren't 100% sure because we have to take him in the extra head because people who we can still just in case you're working with a lab x-ray scope.
And yeah, the same day, so both on that. Yeah. You're like so happy. Like, oh yeah, that's like always the man. Yeah. Going back for watching me. So yeah, so these like sound nice. Thanks for sending me that.
One of those rare moments where people are actually here sort of on time. We're going to actually start at 7:31. How's that? Okay, so what is it? It's April. Welcome to April province-wide rounds, and we have two guest lecturers. One is Dr. Sandra Sirrs, who's a clinical professor at UBC in the Division of Endocrinology. And for those who don't know her, she's the medical director of adult metabolic diseases. But more importantly, or one of the reasons she's here, is that she serves as the chair of the lysosomal storage diseases subcommittee and is a permanent advisor to the Provincial Expensive Drugs for Rare Diseases, EDRD, fondly called. Which is a Ministry of Health appointed committee that actually helps to decide and adjudicate access for drugs to rare diseases. She's also involved in national and international ventures in this as well. And as well, we have Dr. Larry Lynd, who's a professor at UBC as well in the Faculty of Pharmaceutical Sciences. And he's the director of the Collaboration for Outcomes Research and Evaluation and is an associate of the UBC School of Population and Public Health, and also serves on EDRD as a permanent advisor, but also is an advisor for issues regarding access to drugs nationally. So I think between the two of them, we're going to actually have hopefully a very stimulating discussion around some processes and practice of expensive drugs for rare disease and how we would choose to evaluate and access them. And particularly pertinent is some of the drugs that are coming down the pipe for kidney diseases, both current and future. And so this really is applicable. So thanks for coming, and I'll turn it over to you.
Great. Okay, well, good morning. After the hockey game, I'm not sure how many of you are fully with it. I know that Gary's at St. Paul's and we couldn't sleep after the hockey game. We were so excited. For the people at St. Paul's, apparently we have muted you because you are unable to mute yourself. So we'll unmute you at the end for questions. So let me see if I can make this work here. There we go. Some disclosures for you, and the relevant to this disclosures is that both of us we actually do lots of work for government also on this field, so we have put that. So I thought I would talk about this today because of what happened recently, which was in every way just an epic fail with the AHUS case, and we're going to outline for you the scope of the problem, and that's because I think. Most clinicians, and certainly I was this way when I got into this, you think rare diseases, how big a budget impact can it be? In the scope of, so yes, it's $800,000 for an AHUS case, but how much you're paying for coronary artery disease and diabetes and, whatever. In fact, it's a major, major hit, and we're going to show you why. We're going to talk about some alternate strategies to evaluate drugs for rare diseases. Not everything can be a randomized trial, but we can still learn things from the data that we have. Dr. Lynd is going to talk about some research she is doing to sort of define ways around this problem, and I'm going to talk briefly about two of the existing infrastructure systems in Canada. Just to start off, rare diseases actually are not rare, okay? So although each individual disease is rare, collectively they are common because there are so many. There are different ways that you can define a rare disease. The World Health Organization says 1.6 per 100,000, and this goes the range up to the United States definition, which is something that affects less than 200,000 Americans, which would be about 0.5%, okay? Based on those numbers, it's estimated that anywhere between 1 in 50 and 1 in 12 Canadians have a rare disease. And if you compare that then to the fact that at any given time in Canada, according to Statistics Canada, 20% of Canadians have a chronic disease, a significant component of the chronic disease population in Canada are actually people collectively with rare diseases. As we move through this, I'm thinking of when I first got into this field, and I was, opposed, I have to say, to any attempts of administrative authorities to try and put some limits around who I would treat, because in my opinion, my job was to act as an advocate for the patients, and that was my only job. But in fact, that's completely incorrect. And as you listen to the rest of this, I want you to understand that I expect many of you have that feeling right now as I start this talk. And I want you to be aware of that bias as you move forward, because that's the only way that you can also give your mind open to some of the additional information. You function as gatekeepers all the time. You decide who goes to ICU, you decide who goes on dialysis, you decide who gets listed for transplant, who should have CPR, you triage, okay, who needs to get their procedure or their imaging or whatever done faster. That is gatekeeping, and that is something that we all do. We do not fund medications for other conditions that have low utility, even when they are the only treatment option. So, for example, medications for some types of relapse cancer. Okay, even when that is the only choice, we do not fund them. At some point, it is a zero-sum game, okay? So either you can say the health budget is a zero-sum game, and if you take money to put on one thing, you're taking it away from hips and knees, okay? Or you can say the provincial budget is a zero-sum game, and you take money for one thing, and then what are you doing in terms of road maintenance? What are you doing in terms of earthquake upgrades for schools, okay? But at some level, it has to be a zero-sum game, or else you would have no money in your pocket at all, right? They would take 100% of your money, and you would have nothing. So at some point, it is that. Where that point is, I think that's a big question. And these, considering the impact of treatment decisions in one area on other areas, is what is referred to as opportunities costs. And the final thing, which I always struggle with myself, because I, pretty much exclusively deal with people with rare diseases, is it is really important that we not disadvantage somebody because they have a rare disease. But similarly, it's not appropriate that we give them an advantage because they have a rare disease, that we do things for them that we would not consider acceptable for people with chronic diseases. And this is something I struggle with as we go through. Now, I was going to show you some video clips of this case and decided that there was no way I could stand to watch them again. I think my blood pressure was like 300 for the whole weeks that this was going on. An epic fail from the point of view of the patient, like an awful, awful situation for the patient and family, a horrific situation for all the physicians involved, a horrific situation for the government. I tell you, they were absolutely horrified by this. In every way, this was exactly what all the work for the last 8 or so years on the EDRD we have been trying to avoid. A horrified young lady, feeling like her life was in danger, and then we find out that there's a baby, like even worse, oh my God, all over the news. And then the worst case scenario, a politician is making a decision about who should be treated. Okay, so I think everybody in this room and probably everybody in healthcare could agree that that is exactly what you do not want to happen, right? Is somebody who does not actually have the sort of frame of reference of either the disease process or the healthcare system to be making that decision. So it should have never gotten this far. I'm not saying that was the wrong decision. I'm saying that it should have never been in this vein to actually have a politician come out in front of the cameras. The other thing I think that we need to look at is how this impacts the public confidence in the healthcare system, right? This is huge, right? And yet you guys are, busting your balls, if you pardon the expression, every day, right? To try and provide the best care within limited resources. This is not what anybody needs, and particularly not these patients and families. Like, just a disaster. Should have never been there. I'm going to just very briefly show you, though, some of the steps that led to that. I wasn't involved with these. I'm not defending the Common Drug Review decisions on eculizumab, but I suspect that many of you have not read them chapter and verse. So I just want to show you the first time that eculizumab was reviewed by the Common Drug Review, which is the national agency that reviews drugs for their efficacy. It was in 2013. This is the first time they reviewed it for AHUS. Okay, it had already been approved for PNH, as you know. And what they found, as they often do with rare diseases, is that they could not find any conclusive evidence of benefit. And there was only 2 studies that they could look at, which were open label, prospective. This was a chart review. And they see the data are kind of discrepant, right? In this study, people seem to be doing well coming off renal replacement therapy. In this study, not so much. Short duration. And they said, well, they really don't have enough data to tell if it works or not. And actually, in that initial decision, they didn't talk about cost at all. As with many of the Common Drug Review decisions, it's like, well, we don't have enough data. So fast forward to 2015, when in response to quite a bit of appropriate pressure, I think, from clinicians, they were asked by the Government of Ontario to review it again. So the clinicians had come up with a sort of outline of cases where they thought they should be treated, and so they asked the Common Drug Review to review it again, and so that's 2 years later, okay? Drug has been on the market for 2 years. They did another complete review and found no new literature. Okay, this is something I think to remember, right, is that it is not the job of government to develop literature on whether or not a drug works. That is the job of a manufacturer. And in that time, when there was all this push to have AHUS covered, there was no new literature as to whether or not this drug worked for that. So they said, well, we couldn't actually come up with any decisions, so they decide that, okay, well, let's abide with those Ontario guidelines, and that was in 2015. Of course, once a decision like that was made in Ontario in 2015, that set up the problem that we saw last year in British Columbia, because, of course, it's not appropriate that it be treated in one province and not in another. But I think it's just important to understand, like, how little data, in fact, the absence of data that there was that led to those decisions in the first place. One of the things that the CDAC said in the 2015 decision was that it was unlikely they were going to have any type of high-quality data in the future. And this is, I guess, not surprising since 2 years had gone by and no data had been developed. And I think that this is maybe something that people just accept. They say, well, it's a rare disease, so we can't get high-quality data. I dispute that. And this is something that many years ago, actually, Gary and I did this because I was very frustrated with all of the advocacy work I was having to do to try and get the Fabry disease patients treated. And I looked at other types of kidney diseases that were similar frequency. So I looked at cyclophosphamide for the treatment of Wegener granulomatosis, and I looked at Plex for the treatment of TTP. And what I found, I looked at this, I only want you to look at this column here. So these are grade 1 studies, so those are randomized trials, not necessarily placebo-controlled, of course, because the PLEX studies are not placebo-controlled, but with hard renal outcomes, okay? Randomized hard outcomes, death, dialysis, transplantation. And at that point, there were 4 studies of PLEX that met those grade 1 guidelines in TTP, and there were 5 for cyclophosphamide and Wegener's granulomatosis, and none for the Fabry drugs. And that is despite the fact that there is absolutely no financial incentive. There was no pharmaceutical company that was going to gain from these PLEX studies, and cyclophosphamide had been on the market for decades. Okay, there was no financial incentive to have those studies drawn. And if we think about that, the AHUS is very similar in prevalence to TTP, and yet we do not have any of those grade 1 studies. Okay, so I dispute the fact that you cannot get high-quality evidence for a rare disease. I think it just takes more will. The thing about rare diseases, of course, is that the number of doctors involved to treat them is also very small, right? So yes, it's difficult to get patients, but it's actually a lot easier to find out where all those patients are. So with that, we're going to be going back and forth. I'll hand it over to Dr. Lynd, and then I'll be back.
Thanks, Sandra. So we're going to change tack just a little bit, and we'll talk a little bit about economics. We'll talk a little bit about, I've been involved in this environment now for almost 10 years, and I got involved in this, back when we weren't actually dealing with a lot of drugs for rare diseases 10 years ago, and we were arguing, we were right at the front edge of the curve in what we were going to be dealing with over the next 10 or 15 or 20 or 30 years. We better start getting our house in order because we're going to be dealing with this more in the future. So I'm going to talk a little bit about kind of where we're at and where we're going. Bearing in mind, before I got into this environment, I actually practiced pharmacy for 12 years in clinical pharmacy. I worked in the renal ward at University Hospital in Saskatoon for 3 years. So I have been on the front edge and front lines of patient care. And this is really about trying to find ways where we can actually get the drugs into the patients that we want to get into in a way that we're considering the opportunity cost and what the trade-offs are, and can we afford it. I think just to set the stage of why we're talking about what we're talking about, certainly the elephant in the room is price. And otherwise, if there aren't a lot of drugs that we're dealing with right now, and if they weren't as expensive as they are, we wouldn't be having this discussion, but they are. And the problem is in healthcare, this is about the only market where we really don't have a perfect market. Where within a perfect market, where there's no market power on either the supply or the demand side. So when we go to purchase something, at least we feel we're making an informed decision, and we're making an informed decision about ourselves and how we're going to spend the resources that we have, and what are our own personal opportunity costs. If we decide to go and buy a Maserati. I think, we could all in this room go and through the bank, we could finance driving a Maserati if that's truly what we wanted, and we would be willing to give up something in order to have a Maserati, and we could do that. But we don't do that, or at least I didn't. Maybe some of you did. I just can't convince my wife. But anyways, we have a balance of information between consumers and producers. We make individual decisions to maximize our own utility with our own trade-offs of what we're willing to spend on. Whereas in healthcare, we have market failure. We have individuals who have a demand for health, but not necessarily health care. And the only way to one way to get health is through health care. Another way to get health is through, paying for our gym membership, exercising, changing our diet. But there is a demand for health care just through our demand for health. We have information asymmetry between patients and physicians, but also between payers and industry and really all the stakeholders involved, that there's different levels of information we have. Realizing when we make decisions within healthcare, it's not just about our own personal utility, because we pay our taxes and we contribute to providing health care and paying for drugs for rare diseases and paying for drugs for chronic diseases. And we're okay with that, even though we don't have those chronic diseases. So we have an inherent altruism to pay for things that other people in society need. The biggest problem is we have distortion in the prices that we pay given the insurance environment. the user or the consumer doesn't pay. This causes a distortion in demand because there's no cost to the individual, really, at least in Canada. And we have this perverse demand given that we don't pay directly. And also there's no usual market competition between health services. And again, this comes down to the kind of the perversion of insurance. And the example I use is if we think back and we look at the first TNF inhibitor came out, infliximab hit the market at $20,000. What did all the other biologics hit the market at? They hit the market at between $18,000 and $20,000. So there was no market competition because the payer, the insurer, has their revealed willingness to pay, which is $20,000. So the next one comes in at the same price. So we don't have the usual market competition that we would have in a normal market where you and I might be competing on the demand side with our own dollars. And therefore, because of this insurance environment, we get these perversely inflated prices. And one of the problems is we have this gap and we don't really know what the societal willingness to pay is for lots of these products. For drugs for common diseases, we use this threshold of $50,000 per QALY. We've been using that threshold since the late 70s and early 80s, which doesn't account for inflation or changes in cost or technology. We don't know if that's still our willingness to pay, but that's what we use. When we start looking in the rare diseases environment, we have absolutely no idea what our willingness to pay is, given that there may be different levels of altruism and rule of rescue that we're willing to pay for as a society, but we don't know. But that's kind of a long-winded sort of background to why we're dealing with this problem in healthcare. So we know we don't actually have orphan drug status in Canada. There's no such thing as an orphan drug in Canada. We have no legislation like they have in the US and the EU and Japan. The rationale for orphan drug status is, these have been seen as non-commercial therapies to try and provide incentive for drug companies to produce treatments within an environment where there's a really small demand. We have a small patient population. So that was the kind of the original background, and the ability for patients to pay given the apparent need for these high prices given the small patient population, realizing we could probably all in here try and find a way to pay for the Maserati. We're talking about drugs that patients have absolutely no way of affording. They might be able to afford infliximab for their RA if their private insurance doesn't cover it, but they're not going to be able to pay for eculizumab, for instance. So the only way we can get it into our patients is through the insurance system. The support for research and development. So within the US and the EU, the two biggest markets, they provide support for research and development. There's tax allowances, lower evidentiary threshold at license in terms of what Sandra just talked about, and additional market exclusivity, which is in the indication, not within the drug, which is also quite different. So if we look at the US, there's a 50% tax credit on research and development costs for a drug if it has orphan drug status. There's research and development grants for phase 1 to phase 3 trials, and the user fees are waived when you go in to apply to the US FDA for market approval. So you can see right away there's incentivization for a pharmaceutical firm to have their drug designated as an orphan drug because of all these potential benefits that they're going to get. Actually, I'll go over this in the interest of time because I think Sandra's going to talk about this, so I'll just skip this. But in terms of the evidence, and Sandra alluded to it, and I think she'll talk about it again, and I think the question comes up with these sort of limitations, does this lead to a lower evidentiary threshold vis-a-vis a lower bar for market authorization, and therefore perhaps another incentive for pharma to go down the orphan drug route as opposed to the non-orphan drug route? And I'll just leave that as a question, and I have my own personal bias towards that. So when I say we're right on the front edge of the curve here, I think we're beyond the front edge of the curve now. Here's what we're talking about in the future, and think about this in the context of some of the slides that I referred to. I'm going to talk about eculizumab because I think that's probably the one most everybody here is most familiar with. But think about it in the context of everything else all your other colleagues are dealing with in other rare diseases in environments, or even not even rare disease environments, but rare variants of common diseases. So this is the recent forecast in came out in 2017. projections up to 2022 that the worldwide orphan drug market will be worth about $210 billion, which will be double the overall drug market. The average per patient per year cost in 2016 for the top 100 drugs versus the top 100 non-orphan drugs. And when I say the top 100 non-orphan drugs, this is being compared to the top 100 highest revenue generators. This doesn't include all of the drugs across all patients across all diseases. So we're looking at in the orphan environment about $140,000 per year per patient for the top 100 versus the $27,000 a year per patient for the top 100 non-rare disease drugs. If you took that then beyond not just the top 100 money makers for the non-rare disease drugs and took all the drugs, we're talking about more than a 100-fold difference in the cost. The European, here's the issue is the pipeline. There's a forecast in Europe that the European pipeline forecast to be about 56% orphan drugs in 2022. So looking at what's in the pipeline of what we might expect to see coming onto the market by 2022, over half the drugs in the pipeline that we would eventually see in the market, or some of which we would eventually see in the market, would be in the orphan drug environment. And just bear in mind, orphan drug designation comes most often with orphan drug pricing. Here's worldwide orphan drug sales and share of prescription drug market projected to 2022, and we can see what happens to this curve since about 2017 as it goes up to by 2022 we're talking about over 20% of the market being directed at orphan drugs. Again, just think about that then in the context of the denominator and how many patients we're treating with 21% of the market share on orphan drugs and what the opportunity cost of that might be. Here's the top 20. I'm going to skip this. This is just going to give a little closer view at what we just showed down at the left hand of that curve. Top 10 U.S. orphan drugs in 2016 by sales in indications where there's fewer than 10,000 patients on revenue per patient versus number of patients treated. You can see at the right end of that is Solaris with about just about $500,000 versus just over 2,000 patients treated in the U.S., so about $500,000 per patient treated in the U.S. Right below that is, interestingly, is Orkambi, which, if you were watching the news, was also in the news recently in British Columbia. Just another good case example that Sandra could have alluded to. But then just of interest is the average cost or revenue generated per patient treated. Top 20 selling orphan drugs in 2022, and there's eculizumab right in the middle. Interesting, I think eculizumab is an interesting story in and of itself. We can see where it is, and this is really based, at least up until 2016, 2017, on one indication of the revenue that they've generated. But unfortunately for us on the clinical side, or at least on the payer side, this is a complement agent. There's complement everywhere. So they've got numerous trials going on in different indications, and I do a lot of work in respiratory. They're in phase 2 trials right now in asthma. So you think about the implications of that. Given the incentive for a pharmaceutical firm to get orphan drug designation, obviously there's incentive to apply. Given that in the U.S. they don't have to pay any money to apply for a market authorization like you would for a common drug. So here's just a look at the U.S., the EU, and Japan designations and where that curve has been going over time, and we can see it just continues to go up, realizing not all of these will come to market, but many of them will. And with them, they're going to bring their orphan drug price, most often, and an opportunity cost if Sandra is looking for something to use in a new liposomal storage disorder, it's going to be in competition with everything everybody else wants for their particular patients. And I think this comes back to that advocacy versus how can we work in an environment where we can actually get these drugs that might have a benefit into our patients. And I thought this was really interesting. Hopefully you can see this. I assume we're probably all familiar with infliximab and adalimumab. And I got a call from a colleague of mine at Pacific Blue Cross one day and said, Larry, I was looking at, somebody told me infliximab had an orphan drug designation. I'm going, no, that can't be right. So with a little research, we find out that, and this is just two examples of two drugs that have 6 or 7 orphan drug designations, realizing those are going back into the early and mid-2000s. But think of the research and development cost benefits and the incentivization that they have had for the development of these drugs. And I think they've just done a really good job of exploiting the legislation and using the law for not necessarily, I don't think that's within the spirit of what orphan drug legislation was designed to do. So in fact, this is our costs in BC by PharmaCare for 2015 and 2016. Here we see infliximab and adalimumab are number 1 and number 2 of what we spent in British Columbia on drugs, realizing the firms that produce these have got some significant benefits of having the orphan drug designation, and they're generating the bulk of their revenue on the RA and GI side, which I don't think was the spirit of the law. This raises the issue, I think, too, of what has been affectionately known as salami slicing, as trying to find rare variants of common disorders, so in fact they can meet the criteria for an orphan drug designation and therefore get the benefits on the drug development side. And so, just again, another interesting example, and I just picked this because we're familiar with eculizumab, is the market exclusivity for common drugs comes at the molecule level. So if you come in with the first statin, the second statin can come in for hypercholesterolemia. In the rare disease environment, the market exclusivity is on the indication side. So in fact, if you have a drug for an indication, you have market exclusivity within that indication, realizing there's not going to be an opportunity for competition within that environment until that expires. So it's not at the molecule level or at the protein level. It's actually at the indication level, and this is how Alexion has been able to extend the patent by getting multiple indications for eculizumab. So here we have obviously increased market pressures. We've got more drugs in the pipeline with the designation, which is going to bring orphan pricing. We have this public-private sector conflict where, take nothing away from Alexion and all the other manufacturers. They're just doing a good job at what they're meant to do. Their fiduciary responsibility to their shareholders is to generate profit. I'm not saying that we can continue to facilitate that. I'm just saying that this is the environment we're stuck in, where we've got profit maximization in what I've just showed you, in an environment where we have market failure and this competition with this insurance environment, which really is the part of the problem with healthcare, with the finite budget. And we have a disconnect. We have truly a disconnect between, what it costs to produce and what it costs and what the price is, and in fact in an environment where we don't know what the willingness to pay is. And unfortunately, because we don't know that, and if you talk to the Eric Lunds of the world, they'll realize they've probably made some decisions to pay without all the information that they need about what society's willing to pay, and I'll talk a little bit more about that in a minute, and we've just continued to do that. And again, I think we've talked about this, just to put it into the context of opportunity cost, is every time we fund something within this zero-sum game of a finite budget, it has to come from somewhere else, or we have to generate more revenue, so taxes have to go up. We have to sell more LNG, or some LNG or something. I don't know, are we selling any LNG yet? But that could be an opportunity, right? If we generate more revenue, we can cover more things. I'll just skip over this in the interest of time, I think. But this was just... We've talked about kind of the high-level concept of what could we pay for with the same dollars. This was a really good study done by a colleague of mine, Doug Coyle, in Ontario, and he actually used eculizumab as an example, given he sits on the equivalent of the EDRD in Ontario to what Sandra and I sit on here. So he looks at the annual cost of funding Solaris in Ontario to be about $9 million. And he just took some examples of what that $9 million might pay for. 1 additional public health nurse visit per newborn, 200,000 ambulance co-payments, 180,000 physiotherapy treatments, 400 individuals with mental illness to live in the community, 4 intravenous injection sites. And the question comes, as we as a society, what are we willing to trade off? What is our preference? What do we want? Not that we're providing answers, but these are the questions that I think we have that we need to try and answer.
I think Larry mentioned the Solaris. I think Solaris is also being looked at for macular degeneration. This is the tip of the iceberg phenomenon, right? So why do you think that Alexium brought it in for PNH? It was to get that $800,000 price, right? Knowing what else they had coming. It's the same with the cystic fibrosis drugs that Larry mentioned, right? They start them off in a tiny fraction of the cystic fibrosis patients, right, get this massive cost for them, massive price for them, and then, oh my gosh, in the New England Journal, the Delta F508 mutation, right, cystic fibrosis, 1 in 2,500, that drug trialed in the Delta F508, which is the most common mutation. So, we have to be aware of that, I think, when we're seeing drugs for rare diseases, that might not be the only indication. I think that's maybe particularly true, right, with eculizumab. So one of the challenges is actually that the evidence is crappy, and so the evidence is partly crappy because of the inherent nature of rare diseases, where it's difficult to get enough power to address heterogeneity, to decide what outcomes are relevant because the natural history data is crappy. You can't identify confounding factors because you can't stratify because you don't have enough people. It's hard to know how to determine the long-term effects, and these are the challenges in studying rare diseases that lead to most of the studies being of low quality. And in fact, in the case of the AHUS, right, we are treating on the basis of data that is essentially expert opinion, right? Now, we do this in medicine all the time. I'm not singling out AHUS. I can tell you that most of the lysosomal drugs are being treated on that same basis, okay? The PNH, they have somewhat better data. The cystic fibrosis folks, they have somewhat better data, but so I'm not singling out the AHUS, but I'm saying that that's where we are. But we, with respect to these challenges, they are magnified in rare diseases because of the lack of good natural history data, because when you have fewer people, the heterogeneity is magnified, okay, because you can't go towards the mean. The sample, because of this reduced power, you actually may be having studies that are negative that actually have a clinically relevant effect. You may only have power to detect an 80% difference, but what you actually had was a 30% difference, which in any other sphere of medicine would actually be significant, right? Also, because you can't stratify, it makes it difficult to decide which groups might benefit, and you can't stratify because you reduce your power. And often the results are not normally distributed, which means either that you have to use statistics that are unfamiliar to many clinicians. And I can tell you in the case of lysosomal diseases, what you often have is a bunch of people who are, who should not be doing clinical trials because they're rare disease doctors. We should not be doing clinical trials. And they don't understand statistics at all, and they are applying the inappropriate statistics and therefore coming up with conclusions which are not actually validated by the data. But, we can actually learn things from other types other than randomized placebo-controlled trials. Crossover studies, everybody is going to be familiar with these. These have more power than regular studies because each patient is his own control.